All right, guys, welcome to our next Gonstead Fundamentals Club. Glad to have you back. Just so you know, this video will be kind of a continuation off of our last video that Chris and Rachel made. So if you're confused on anything throughout our video today, make sure to go back and refer to that. Also, make sure to check out our Facebook and Instagram pages because you can find our worksheet that we made to go along with this video there. A big shout out to our officer in training, Kyle, who really helped putting that worksheet together. He did a great job, so make sure you check that out. So today we'll be going over PI, PIIN, and PIEX ilium misalignments, and we will be going over the push move corrections for those misalignments. Don't know if I mentioned this yet, but I'm Patrick, a Gonstead Club officer, and once again we have Marcos here to help us out with today's video. So let's get right into it. Today we're talking about 3 misalignments. All of them happen here at the sacroiliac joint. So PI, posterior inferior, we're talking about the ilium right here rocking back and down the articulation. Keep in mind the sacroiliac joint is a fairly large size joint, ear shaped or auricular shaped, about 2 inches long. And you also have to consider the anatomy when we are thinking about these misalignments and how to correct them. So once again, the first misalignment we're talking about is posterior inferior. If you watch my thumb here, representing the PSIS, that's rocking down and back this way, down the articulation. Combined with a PI in a married listing would be a PIEX, where once again it'll rock back and down, and it will also rock outwards, so externally. The reason those two are considered married is they tend to do the same thing of gliding down the articulation, and they will lower the femur head together. Both of those components, the PI and the EX, will both lower the femur head, which will actually shorten the leg on that side. Next, we would have a PIIN, where once again, the ilium will rock down and back, but instead of rocking external, it will rock internal. So the PI will lower the femur head, the IN will actually raise the femur head. So we have to go to our x-ray and our Gonstead analysis to determine how those two components are working together and maybe canceling each other out to an extent to figure out what that's doing to the femur head height and the patient's leg length. So with that said, to figure out which of these listings we are working with, you're gonna rely very heavily on all 5 components of the Gonstead analysis. The A to P film is really essential for determining the difference between a PI and an AS, another misalignment that you'll learn about coming soon. That's really the best way of determining PI versus AS. So x-ray analysis is essential here. In addition to x-ray analysis, you have your motion palpation, your static palpation, instrumentation, the rest of your Gonstead analysis to help you determine what that listing is. So now Marcus is going to take over. He's going to talk about the static palpation findings and the motion palpation findings that you'll find with each of these 3 misalignments. But really quickly before we get to that, I want to mention that on an x-ray A to P film, what you would find for a PI ilium is a longer measurement for that ilium compared to the other side. You will find a larger obturator foramen compared to the other side, and you will find the femur head height typically is dropped on that side as well.
All right, thank you, Patrick. So now what we're going to go into is our static and our motion palpation. So I'm going to first show us on this specimen here, and then I will go and show it on the patient as well. It's important for you to see what we're doing here, and this is what Rachel and Chris went over already last fundamental club for you guys, but just a little recap. Just again, the more you see it, the more sense it'll make as you go on. So when we analyze the pelvis, the patient is seated on the chair. This is where we do all of our analysis primarily, unless the patient is super acute and they can't sit upright. But for the other 99.9% of the time, the patient is seated in the chair. Okay, so when we're statically looking when we're visualizing and even statically palpating, we're going to investigate the SI joint of what Patrick just said. So the misalignments are based on what the PSIS is doing. This is our reference point for everything. It's not just any bit of the ilium, it's this point right here. So this is what we're comparing on both sides. So statically palpating, like Chris and Rachel said last time, we're gonna start and feel, is there any pitting edema? Is there any tenderness? And we're gonna first investigate the top of the SI joint. So what we're gonna do is we're gonna roll in to the top and feed in a little bit. And if that's tender, that's more indicative of a PI ilium. Again, posterior inferior. As you can see from the side right here, as this rocks posterior inferior, the top of the joint opens. So that's where the edema will pool up, and that's why it's tender in that area. If we're palpating for an EX is just, as Patrick said, an external rotation. You can see the whole backside of the joint will be open, so it could be tender on any point around that posterior part of the joint. For the IN part, you're not going to be able to really palpate that because as this rocks IN, we're looking at the anterior part now, the anterior part will open. So it's hard to really see any pooling edema when there's an IN, and actually the other side, the non-subluxated side, will look like it's messed up because of the edema that's there, but really the IN is causing the edema to be on the anterior side. Okay, so that's just some static and visualization we can do. Motion palpation, what we're gonna do is we're gonna put these 3 fingers in the SI joint. So we're not just on it, we're inside of it. So this is gonna allow us to feel how the ilium and the sacrum articulate with each other. So my 3 fingers are gonna be in the SI joint. One at the superior part, one in the middle, and one at the inferior part of the joint. I'm going to start by rocking the patient towards me a few times. And when I rock the patient towards me, the sacrum should rotate in and down. So as I am going back and forth, I'm feeling, is the sacrum rocking in and down? Then I'll do another 2 or 3 lateral flexions, and I should feel the ilium rock up and in. So I'm trying to pay attention at what each part is doing. Is it properly rocking either as the sacrum in and down, as the ilium is rocking up and in? Okay, that's only when I'm flexing towards me. When I'm flexing away, I am going to feel the ilium rock down and out, and the sacrum is going to rock up and out. Okay, so away from the SI joint. So that's what I'm feeling when I'm palpating, and it's a lot going on at once. So what I like to do personally is I'll focus 2 or 3 lateral bends on just the sacrum, and then do another 2 to 3 lateral bends on focusing just on the ilium and saying, is it doing what it's supposed to do, moving that way? Okay, so now I'm going to show you how to do this with the patient. So what we're going to do is, again, they're in the seated position, and we're going to expose the area we're analyzing. Again, we're always going to be skin on skin because you're going to lose a lot of your sensation if you're trying to go through this extra layer, and you're going to miss a lot of information that is very important to feel. So again, we're going to search for the 2 dimples in the patient's back right here. I'm going to use my 3 fingers and cup the inside part of that joint. Now I'm going to again laterally flex twice. I'm going to feel, is the sacrum rocking down and in? Now I'm going to feel, is the ilium rocking up and in and approximating towards the sacrum? Okay, after I see those 2, I can start getting a listing in my head, and we can go through that in a more advanced time. But for right now, what you guys should just be focusing on is which side is not moving properly compared to the other. So I'm going to rock twice towards me to feel the sacrum, twice towards me to feel the ilium. Then I'm going to rock away 2 times to feel the sacrum, and 2 times to feel the ilium. Again, I'm focusing on just one part because if I try and feel and understand too much, I'm probably going to miss a lot. So that's what we're feeling for the right SI joint. Now to know if it's stuck, we need to compare it to the other side. So you're going to walk around, 3 fingers again, right on that SI joint, and you're going to laterally flex towards you again, and then laterally flex away. it should be pretty obvious which side is stuck because it's comparative. Which side is moving less compared to the other. So if you're feeling like, oh, this one's not moving as much as it should, but then you get to the other side and you're like, oh, that's definitely not moving. You know which side is the stuck one because it's not moving compared to the other side. Okay, so that's what we're doing for motion palpation. It can help you get a listing, but another way to help you get a listing is I'm gonna have Patrick stand up for me. And what I like to have him do is I like to have him march in place with his eyes closed and looking straight ahead. For just a few steps, I'm gonna say, okay, stop. And now this is another way to help us find our ilium listing. So that was just used to find which side was stuck. Now this can help me find what the listing is. As you get more advanced, the palpation can also help you find what the listing is. But for right now, for the fundamental club, let's just use the palpation to decide which side is stuck. Then we can start using this to see what the listing is. And again, the x-ray analysis and everything else we have in our system to really point us towards the exact listing, the exact bone to give the right adjustment. So now we're gonna have him standing like he did after marching in place. We're gonna go down and we're gonna always tell the patient, I'm going to put my fingers to where your hamstrings meet your glutes. If you say before them, it's just gonna help me understand how your pelvis is how your pelvis is sitting. They'll understand and they'll let you do it. So what you're gonna do is you're gonna go slide down and under, and right where the hamstring meets the glute, you're gonna kind of place that finger up there and then place that finger in there. As you guys can see, my right finger is lower than my left. That is telling me that this right side is posterior inferior. And the reason that is because if you just look at basic anatomy, the glute sits and attaches here and it covers the whole ilium. So if this rocks posterior inferior, it's gonna lower the gluteal fold compared to this side, okay? So that's what we're looking for. So after I do this, I'm going right to that attachment site so I'm not getting any atrophy or hypertrophy of a glute muscle. I'm going to where the attachment site is in the gluteal tuberosity on the femur. So going right to there, I am for sure seeing that this right glute is lower than the left one. So that's telling me this side is posterior inferior or this side is anterior superior. It's not telling me what to adjust. It's which side to adjust. It's telling me what the listing is on each respective side. So now we're gonna come over top and we are going to look at the gluteal contour, okay? So as we look over, we can see that this side is flatter and this side is more bunched. The flatter side, again, due to just simple anatomy and simple attachment sites, the flatter side will be the IN, the internal side, because it's gonna make us go here and it's gonna flatten out the glute. The EX side is gonna bunch up the glute because this attachment site just became a lot more compressed right here. So now that we're able to see, this side looks like a PIIN and this side is an ASEX. What's gonna tell me what to adjust is my palpation that I did to see which side was fixated. Now I know what the listing is based on which side I'm going to adjust. All right, so now Patrick's gonna go over how to do these corrections, and we're gonna go over quickly just some patient placement one more time just to get in your head, and then we'll show you how to fix these things.
All right, guys, so before we show you these setups to make these corrections on our 3 listings on a patient, we're gonna show you on the spine, once again, the spine model. Before I place my patient on the bench, I want to really emphasize one very important thing that you have to consider when you're making these corrections, and that would be the angle of the SI joints. So when I lay my patient on their side, I have to remember that those joints are at about a 45-degree angle. If you can see the joint line right there, when the patient's straight onto the camera there, that joint line is going at about a 45-degree angle. It's not straight towards you. So when you're making these corrections, when the patient is on their side, your thrust is not going to be directly posterior to anterior. You have to keep in mind always that joint line, because that will play a very key role in making those adjustments go a lot smoother. So with that said, let's go through our 3 listings, our contact points, and how we're going to be making these corrections. So On the pelvic bench, the patient will be sidelined, just like Chris and Rachel showed you in our last video. And we'll go over that really quickly with the patient as soon as we're done here with our spine model. So for a PI correction, your segmental contact point is going to be the inferior aspect of that PSIS. And you're going to be contacting that spot with your fleshy pisiform. Okay? One thing I want to emphasize with that is you are on the inferior side of the PSIS. And the reason I emphasize that is because so many people have a tendency that they want to get inside on that part of the bone, which would be okay for a different misalignment, but for a PI, you want to be on the inferior aspect of that PSIS right there. So you would take your tissue pull with your superior hand, and your tissue pull is always going to be in the same direction as that line of correction. So you're going to tissue pull I to S past your contact point, and then you're going to go ahead and feed in your contact point in the same direction as the tissue pull, which is the same direction as that line of correction. Once you have your contact point set, it's very important that you don't lose it. So hold that once you go ahead and set everything else up before you're ready to make your correction. One last thing I want to mention before moving on to the other misalignments is stabilization. When I set my hip on my patient to stabilize, I really want to picture my stabilization going through my patient's hip, through the hip on the table, and through the table itself. So imagine a line going in that direction, straight through the patient into the table. We don't want to place our stabilization on our patient's hip and roll them this way, and we don't want to roll them that way. We want to send their hips towards the table for all of these corrections. Very important. So once again, the PI segmental contact point is right there on the inferior aspect of that PSIS. For a PIEX, this ilium has rocked posterior and inferior, and it's come out. So we want to contact that outside part and the inferior part of that PSIS. So right there on the outside of the PSIS. Once again, you would tissue pull, roll in your contact. Once you have that contact, don't lose it. And then stabilization is going to be the same. Last but not least, we have our PIIN. And one thing I forgot to mention for the PIEX is when you roll in that contact, as I said, you're going to go in that line of correction. You also want to include the torque that you're going to have for that correction. So for a PIEX, the ilium has rocked down the articulation, so your torque is going to rock up the articulation. Don't look at the fingers. The fingers are not delivering the adjustment. I'm talking here at my pisiform. The torque should go up the articulation just like that. So when I set in my contact, I'm also adding that torque. The reason I was reminded of that is you're going to do the same thing for the PIIN. For the PIIN, the ilium has rocked down and back, and it's rocked in. So I have to contact on the internal side of the joint to bring it back out again. So just there on the inferior and internal aspect of the PSIS. Once again, I'm going to tissue pull past my contact point in that direction that I'm going to deliver the thrust, and I'm going to follow it in with my contact point, and I'm going to include that torque. So in order to include that torque, I have to start with my fingertips pointing up towards me, and I'm going to torque down the articulation this time. This is a bit of a hard one for people to wrap their minds around because the thrust is going inferior to superior, but the torque is coming down the articulation at the same time. So once again, tissue pull past it, fingers pointed towards yourself, roll in that torque as you're feeding up. And once again, once you have that contact point, make sure you hold it. All right, guys, so Marcos here is going to show us the proper way for a patient to get placed down on the bench, which was went over in our last video if you want to revisit that. Before he goes down, you always want to remind your patients that you're going to need that skin-on-skin contact. So it might be best before they lie down to ask them to go ahead and undo that top bun, so that way it's easier to lower the waistband just low enough to get that PSIS exposed. So
I'm going to start with my hand, trying to make sure it's about arm's width away from the pillow. Then with 2 arms, I'm going to keep my spine straight and bring my feet up. Straighten one leg, bend the other. Now I'm ready.
Now another thing to go along with that top bun getting undone, if your patients are wearing really tight pants that are kind of restricting their knee from getting high enough to where you need it, you can always go ahead and pull their pants up this way for them, and that might, and pull up here as well, that can get them to raise their knee up to where it needs to be. Now really quickly, some things you always want to check once your patient is placed. You want to make sure that everything is in a straight line. I like to use the edge of the bench as my reference point, and I want to make sure that my patient is parallel with that edge of the bench. So I'm going to check, I will start up at the head of the patient, make sure that he's not chin tucked too much. I also don't want him too extended. So if my patient was, Marco seems fine here, but if he was, I would kind of just grab his head and bring him to where I want it. Next, I would check their shoulders. Remember this inferior shoulder over on this side, I want to tuck it down and slightly anterior to, I usually use that CT junction as my landmark. So pull it down. It might be a good idea to check with your patient, make sure they don't have any shoulder issues before you go ahead and make that tuck. So head is in line with the CT junction. I follow the spine down to where his hips would be. So right here, I would probably ask Marcos. He seems to be a little bit flexed at his hips. So I can always lift this top leg for him a little bit, and it'll make it easier for him to tuck his hips towards me. And next, you want to go down to the knee. Make sure that this bottom leg is as straight as you can get it. And that way they should be parallel with that edge of the bench. Once you have your patient in that perfect patient placement, you are ready to go ahead and do your setup. So we're going to start off with that PI misalignment. So remember, you always want to protect your back. So when I go to get my contact point, I don't want to kind of like bend over the table like this looking for Marcus's contact point. I want to keep a nice curve in my back, an athletic stance, and I want to roll my patient towards me. That way my back stays healthy and not straining too bad. So remember, God said system, always skin on skin. I want to expose Marcus's PSIS. Remember, visually you can use those dimples to help you find it. There's Marcus's right there. And keep in mind, your tissue pull, very essential. It's the first part of your adjustment. It gets the bone going where you're going to end up sending it. So for PI, remember, we're going to be on that inferior part of his PSIS. So I'm going to start my tissue pull down here. I'm going to pull the tissue past my contact point, and then I'm going to go ahead and feed in with my fleshy pisiform, and I should land it right underneath that PSIS. Once I have that spot, I do not want to lose it. I need to hold that. So sometimes when I get distracted with everything else, I may slide around on his skin. If that happens at all, I've lost that contact, so I probably need to restart. So once again, tissue pull past your contact point, roll in that fleshy pisiform and hold it, okay? This stabilization hand is gonna go thumb over the humeral head, and my fingers are gonna kind of go over his clavicle, and I'm gonna use that to send his shoulder up to stretch out the spine. And a good reference point to use for that is that top corner of the table. Send it up towards that top corner. What you don't want to do is send it backwards, and you also don't want to kind of flex the patient down at all. You want to distract that shoulder, take out some of that excess slack, send it up towards that top corner. Once I'm here, I'm ready to roll the patient towards me a little bit more. As I'm doing that, this front leg of mine, my toes are pointed towards the head of the table, and this back leg is going to get ready to go ahead and set the stabilization on my patient's hips, just like that. So I'm going to go ahead and remove this hand real quick. I want my ASIS to end up right behind Marcos's greater trochanter, and that ASIS is going to deliver that stabilization that I talked about on the spine model. So I don't want to do this. I don't want to rotate Marcos with my hips at all. I want to send him like that, towards the table. I'm essentially using my hip to pin him. If I had maintained that contact point and maintained that stabilization, the final setup should look something like this. Now, my forearm here is going to dictate what my line of correction is. So remember on the spine model, Marcus, if you can stay there. On that spine model, I was talking about that angle of the SI joint on that 45 degrees. So when I'm contacting Marcos for a PI, I need to get my elbow in line with that joint. So tissue pull, sending the contact, stabilization, stabilization, sending his hips towards the bench, and I need to get that elbow low enough to get through that line of the joint. The correction should not be a massive body drop. It shouldn't be a shot with the arm. I should have him just at that point of correction before I deliver a small thrust through that plane line of the joint, all along stabilizing. The better I stabilize, the less force the thrust will need, which is one of our goals in delivering these adjustments. So next we'll talk about the PIEX. The stabilization is going to be the same. One difference is going to be our contact point. Remember, I'm going to end up on that external part of that PSIS. So my tissue pull is going to go past that contact point, and I'm going to follow it in with my contact point, with my pisiform. For this adjustment, I really want to be sure that I'm not making that EX worse. So if I get my elbow too low, I can make that EX part of that misalignment worse. So I'm going to keep that in mind. My elbow should stay higher up. That way I can take out the PI by lifting up and forward, but I'm going to keep my elbow slightly closer to me so I'm sending the EX back inwards. Last but not least, that PIIN. For this one, we're going to tissue pull past our contact point, which is the internal part of that PSIS. So I'll tissue pull past it. Remember, I want to face those fingers towards me because I'm going to set in my torque. The torque should look something like that. I don't want to torque any further than that. So I'm going to tissue pull past my contact point, fingers towards me, set in some torque. Once I have that contact point, I'm going to hold it, and then I'm going to set in my 2 points of stabilization once again. When I've preloaded that torque, when I deliver the adjustment, the torque should not look too exaggerated. Just like the adjustment, it's even smaller than that. Sometimes we tend to over exaggerate. Marcus, you can go ahead and sit up. Sometimes we tend to over exaggerate our torque and also our tissue pulls just to show you guys what it will look like, but it's really just a small but key component to those corrections. Last but not least, I want to mention how we talked about how these misalignments can affect the femur head height and how the femur head height will affect leg length. The goal of these adjustments is not to even out your patient's legs. Most people will have an anatomically short leg. That's natural, that's what their body works with. So we're not really striving to even out those legs. We're just trying to remove these misalignments and help our patients' bodies function better.
Yeah.
Anything else to add?
That was amazing. Thank you. Thank you, Kyle, again, for making this awesome sheet. You did a great job. He worked really hard at it, and Patrick did as well. I was just filling in for him today. But yeah, everything that was said is very important to keep in mind. A lot of times, like Patrick just said, people get so caught up with evening out the legs when a lot of studies point to over 90% of our population has a leg length difference anatomically. So if your goal is to straighten the legs, you're actually going to probably cause a subluxation to occur because their legs aren't naturally even and they don't function even. All right, so we're just really trying to remove the ilium subluxations when we're doing this and let the body adapt itself, and we're not trying to force it to be structurally sound. But everything else was great, and we hope to see you guys. We have an advanced video coming tomorrow, and then fundamentals again on Wednesday. So we look forward to seeing you all soon, and thank you, Patrick and Kyle.
Make sure you guys practice. If you don't have a bench you can practice on, at least practice that palpation. Practice whatever you can. Grab a roommate, grab a friend. Practice, practice, practice.
Thank you, guys.